Good afternoon, everyone. Thank you for joining us today. My name is Melissa DeMars, and I'm a behavioral health consultant with OPEN, the Overdose Prevention Engagement Network. Welcome to today's webinar on alcohol use disorder, harm and risk reduction strategies. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and press send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work CE, and McBAP credit for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar. We'll also email the continuing education credit information after the webinar today. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative, evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain, and who can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. Many of our webinars offer free CME, CEU, and McBAP credits. And for prescribers, all our credits also qualify for the DEA required substance use disorder training. We provide medication for opioid use disorder training for providers. And this year we're incentivizing primary care providers with $250 to complete one of our MOUD trainings. We hope this encourages confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform prescribing. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for both patients and providers. Our patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication and disposal options. We assist groups all across the state in hosting local take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants. And we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. We offer overdose rescue support. So we also fund implementation of naloxone vending machine and distribution boxes. We also offer naloxone administration trainings. These trainings are offered as live, virtual, or free online training courses. You can access more information about all of these services more directly using these QR codes or visiting our website. OPEN understands that effectively addressing opioid use disorder and other substance use disorders requires deep collaboration and tailored solutions to meet the unique needs of each part of the state. We continue to provide regionally dedicated behavioral health consultants. Each work directly with physicians, physician groups, and community organizations in your area to help build connections and networks locally. And with that, I'm going to introduce our guest speaker today. Dr. Allison Lin is an addiction psychiatrist and associate professor in the Department of Psychiatry, as well as research scientist at the VA Ann Arbor Healthcare System. Dr. Lin is also director of the Addiction Psychiatry Fellowship Program, president of the Michigan Society of Addiction Medicine, and American Academy of Addiction Psychiatry Research Committee chair. Her research is informed by her clinical work, treating patients with addiction and recognizing the potential for healthcare systems to help address this major public health crisis. Her research focuses on identifying actionable contributors, gaps and disparities in access and quality of addiction care using large healthcare data sets and developing new interventions and models of care, including through use of telehealth, to improve reach and delivery of evidence-based care to patients. And with that, I'm going to hand it over to you, Allison. I'll stop sharing and you should be able to screen share.
Thank you, Melissa, for that very kind introduction. Let me try my screen share. So I'll also just highlight a few things about myself in addition to Melissa's introduction. So I'm an addiction psychiatrist. I direct our addiction psychiatry fellowship at the University of Michigan. Folks might also know me in a couple of different roles. I'm one of the on-call physicians as part of OPEN. In addition, I'm the current president of the Michigan Society of Addiction Medicine. And so I'm always happy to talk to folks separately outside of this presentation for folks interested in any of those kinds of organizations or the work that we do. In addition, I also lead a program in the Department of Psychiatry called MyACRE. It stands for the Michigan Innovations in Addiction Care through Research and Education. It's really about translating the work that we do, the knowledge that we generate to actually improving care and having impacts in patients across our communities. So today I'm talking about alcohol use disorder risk reduction approach. Actually tweaked my title a little bit. I think for some people who's listening to this talk today, what I say is going to seem just totally par for the course for you. For other people, this might actually seem pretty new or even surprising or shocking. And so part of my goal today is just generate a conversation about how we can think about approaching our patients with alcohol use disorder in general with a very patient-centered approach and acknowledging a lot of the challenges that we all face. Many of us have been exposed to this idea of harm reduction, but oftentimes that's been applied for people with drug use disorders, opioid stimulants, et cetera. I would say what I'm talking about today is related but slightly different, and that's why I've reframed this as a risk reduction approach. And what I'm really emphasizing is that the whole community, the whole addiction community has actually been evolving over the last 10 or so years to really trying to think about a risk reduction approach also for alcohol use disorder to address a lot of the gaps that we know exist for people who need care. And I'm going to emphasize a lot of that. Lastly, I will say that very much the goal for me in doing a presentation like this is to generate discussion. So this is not meant to be a one-way lecture, but please, please, please feel free to add into the chat box any questions or thoughts that you have, controversial questions, not so controversial questions, challenging experiences that you've had in applying different approaches to care for patients with alcohol use disorder. We'll definitely try to generate discussion around those questions. All right. To start, this is kind of a summary of the objectives and outline. So first, I'll focus on the impacts of alcohol use disorder. Then I'll talk about the major current treatment gaps. Then I will move to talking about what a risk reduction or a patient-centered approach for alcohol use disorder really means and can look like. And finally, how to actually, what that approach really means when it comes to interactions with patients and the potential that it can have in terms of addressing current gaps. Most of us know this, but still really important to highlight the impacts of risky drinking and alcohol use disorder on physical and mental health in the American population. We know that over 100,000 people die annually from alcohol-related causes. That's not just or primarily related to overdose, although quite a number of people die from alcohol-related overdose as well. A lot of this is from the cumulative effects of alcohol on the body. Also has tremendous economic impact for this country with almost $250 billion annually. And also extensive health impacts. I know sometimes there's controversy around this. There's actually not controversy around a lot of the known impacts that we know from excessive drinking, including increasing risks of different cancers, obviously increasing risk of liver disease. That's the thing that most people think about. It's really one of the primary causes of liver disease in this country and reasons for liver transplants. but also just the tremendous diverse impacts that excessive alcohol use and alcohol use disorder has on the individual as well as their families, exacerbating mental health conditions like depression, anxiety, exacerbating a person's ability to manage other physical health conditions, and also obviously exacerbating impacts on family life and functioning. It's important, though, to note that when we think about alcohol, there is kind of an important distinction when it comes to other substance use disorders, in particular, things like opioids or stimulants. Many people, drink alcohol at different levels. It is not an illegal substance. And has been around for a very long time. And so what that means is that when we talk about risk, we really think about it on a whole spectrum. And really what, we're focusing on today is among people who've really had, are drinking at levels or who've developed consequences related to their drinking. And there's basically that kind of triangle of risk. You can think about, at the very bottom is, anybody who drinks, which might be a majority of this country. And then above that are people who are drinking at higher levels or levels that might be associated with health consequences. And at the very top of that are people who've developed an alcohol use disorder. In terms of the way that we define or think about risk, that group in the middle, so what we call risky drinking or hazardous drinking, is actually defined in a couple of different ways. The key things being that it's oftentimes defined, first of all, it's sex dependent. There are different kind of thresholds for both men and women that you see here. Greater than 3 drinks in a day or 7 drinks in a week for women, greater than 4 drinks on any given day, or greater than 14 drinks in a week is considered risky drinking for the general adult population. But then at the top of that kind of triangle would be people who've developed an alcohol use disorder. And interestingly, that's actually not defined by the quantity of alcohol use. It's really a medical condition, a chronic medical condition defined by the symptoms and the impacts that alcohol has had on that person's life, which I'll talk about next or in a little bit. We know that alcohol, that whole spectrum of risky or hazardous drinking to alcohol use disorder has tremendous impacts. We know that about 38 million adults in the US qualify for at least that risky drinking category, but only very few of them has ever talked to anybody about their drinking or concerns about their drinking. So only 1 in 6 has ever talked to a health professional about their drinking. This slide outlines some of the other kind of risky drinking categories that I mentioned. Obviously, risky drinking, any alcohol use in pregnant women and any alcohol use in those under age 21 is also considered risky drinking. So then going to the very top of that triangle, when we talk about people with alcohol use disorder, kind of similar to other substance use disorders like opioid use disorder, stimulant use disorder, it's really a medical condition defined by the symptoms or the impacts that a substance has on the person. These are the 11 symptom criteria defined by the DSM-5. Where all about a specific amount of alcohol use. They really are based on the impacts of drinking and specifically how someone manages when they're trying to cut down, and also how someone manages when they're actually actively drinking. So is someone having cravings when they're not drinking? Is someone having negative impacts on their family life, their work life, their physical health, their mental health in the setting of alcohol use? Are they having potential withdrawal symptoms when trying to cut down? These are what really defines an alcohol use disorder. In terms of severity, the whole range, similar to other substance use disorders, mild alcohol use disorders, 2 to 3 of these symptoms, moderate is 4 to 5, and severe is 6 or more. I emphasize this not because of the individual symptoms are key. It's really to emphasize again that there's a whole diverse range and a heterogeneity in terms of the population who experiences problems with drinking. And these problems are not necessarily defined by the amount of drinking. So for example, you can have someone who meets criteria for a moderate alcohol use disorder with potentially like fairly low amounts of drinking, or in contrast, you can have someone with higher amounts of drinking who do not meet criteria for an alcohol use disorder. And really kind of that impacts and how someone manages with either being able to cut down or their drinking on their own, or how someone is managing the level of drinking that they're currently at. Those are really kind of key symptoms defining drinking, with the caveat of the slide that I showed before, which is that we know there are certain levels of drinking that might be associated with different health outcomes. And yes, and I would say in my mind, like the key hallmark of an alcohol or any other substance use disorder is pretty simple. Like you don't have to memorize all 11 symptoms. It's this idea that someone has a difficult time managing or controlling or cutting down their substance use despite negative consequences. So that means that that definition has two parts. The first part is having a hard noted that is that alcohol use disorder is extremely prevalent. Survey on drug use and health, and the most recent data from 2022 shows that among basically a nationally representative penalized age 12 or older, 29.5 million meet criteria for a past year alcohol use disorder, and that actually exceeds all other drug use disorders combined. So that exceeds the number of people with marijuana, cocaine, other substance use disorders combined. And that's something that we forget sometimes because obviously our country continues to struggle with other types of epidemics like with opioid and such. And I do a lot of research and work around substances, but I always emphasize to people that first of all, I'm substance agnostic as an addiction psychiatrist. It's really about working with all folks who struggle with substances and alcohol use disorder being an extremely common form. In addition to it being very prevalent, we also have seen tremendous increases in the impact of alcohol in our society. I think a lot of us heard news during the pandemic that alcohol-related mortality and drinking had really increased. And this is really a figure emphasizing that. This is a figure from the CDC that shows kind of trends in alcohol-related mortality over the years. And what's kind of scary is that, for a while, it was actually fairly flat. But over the last 5 years or so, we really saw a dramatic increase in alcohol-related mortality, in particular in rural populations, but also in urban populations, and especially coinciding with the start of the pandemic. And we're still kind of trying to understand if those impacts or that increase will continue to last. My guess is that we'll continue to see some of those effects long-term, unfortunately. The good thing though, and the reason why we're having this conversation today, is that we have effective treatments specifically for people who've developed an alcohol use disorder. Importantly though, to emphasize is that in contrast with other substance use disorders, in contrast, for example, to opioid use disorder, we have really many decades of research that support effectiveness of different treatments, including both psychotherapy treatments for alcohol use disorder as well as medications. And so in this slide, I'm emphasizing all of the different specific psychotherapies that have been shown to be effective for alcohol use disorder. That includes cognitive behavioral therapy, motivational enhancement, 12-step facilitation, contingency management, and other newer behavioral interventions. One thing that I want to emphasize is it's really great and important that we have and we use this whole arsenal of tools in our toolbox. First of all, we know substance use disorders can be very challenging for the person experiencing it and to treat it. And it's really important to have this array of effective treatments and to actually use the effective psychotherapy. I know some people think, oh, well, one psychotherapy is the same as another. It's actually not. All four of these approaches actually have pretty substantial differences. Sometimes they can be really helpful when combined. For example, motivational enhancement combined with cognitive behavioral therapy, but they work in different ways. For example, contingency management is really about increasing saliency of reward and things like that, reinforcing positive behaviors in particular. 12-step facilitation is really about engaging someone with local community supports and stuff. And so it's helpful to have these different options because they can be tailored to the specific patient. Similarly, we have a whole host of medications for alcohol use disorder. In contrast to opioid use disorder, where we're prioritizing typically 2, maybe 3 medications. With alcohol use disorder, we really have this arsenal of treatments. I just showed you quite a number of different effective psychotherapies, and now we have a list of 3 FDA-approved medications, which are the top 3, naltrexone, acamprosate, and disulfiram. In addition, the bottom 2 are not FDA-approved, but they have substantial evidence supporting their use in some populations too. This is a busy slide, so I'm not going to go into details in dosing or talking about side effects in the medication, but I really want to emphasize that, first of all, we have different options. The second thing I want to emphasize is that these medications target and work in some different ways, which again is very helpful because similar to the behavioral interventions, it means that we can try to tailor a treatment to a person depending on where they are, what are the specific symptoms or issues that they're dealing with. In particular, I would say naltrexone and acamprosate are both real effective at reducing urges and cravings. And in addition, we can prescribe these medications for someone who's trying to cut down their drinking and who might be actively drinking. In contrast, as a lot of folks know, disulfiram, which is also called antabuse, someone can only take that once they've stopped drinking and had some period of having alcohol out of their system, because the medication works really as a deterrent in terms of having people drink while on it. And so when people ask me, and I get this question all the time, is it okay for me to be taking medications even if my patient is drinking? And the answer is yes, if it's naltrexone, acamprosate, also topiramate and gabapentin to some extent. But that's an important thing to recognize, is that these medications, the first two, can be used to help someone try to reduce their drinking, whereas disulfiram is particularly consider for folks who've had some period of detox or abstinence, who have a low likelihood of drinking, and it's really kind of to help them prevent that. The one challenge with disulfiram, though, is if you have a person who's even detoxed from alcohol and you know that they have a very high risk of relapse based on their prior history and their circumstances, that's not a medication I would recommend, because it can come with other side effects and things like that. But for naltrexone and acamprosate, we can definitely prescribe them. We can prescribe them in combination for a person. And also the last two medications, topiramate and gabapentin, they also work in different ways. Gabapentin has also shown to be effective, obviously, in helping someone reduce their drinking to address or alleviate withdrawal symptoms too, in addition to benzodiazepines. So again, my goal in showcasing these two slides are not to emphasize the specific treatments. So a host of, 4 or 5 options for behavioral interventions or counseling or psychotherapy, and a host of 4 or 5 options for medications. It's just to emphasize that we have multiple different options and they work in different ways, and they might help patients in different ways. But the problem is that the vast majority of people with alcohol use disorder do not receive any of these treatments. Estimates nationally show that less than 10% of people with alcohol use disorder receive any effective treatments. That is far lower than the current treatment rates for opioid use disorder, which is closer to 30% or a little bit more. So even though alcohol use disorder has been around forever, we've also had these treatments, effective treatments, around for forever. The actual use of these treatments remain extremely low. And I also want to highlight that in terms of comparing the treatments, some people ask, well, which one is more effective? In the studies that have tried to compare different treatments, including different medications and different psychotherapies, what they found is that on average, they're about equally effective. So there's not one that on average, like if we gave it to everybody with an alcohol use disorder, is known to be more effective. And what that means is that both medications and psychotherapy can be effective, but again, only 10% of people receive any treatments. And actually for medications, the treatment rates are even far lower. Like 2.1% of people with an alcohol use disorder received an alcohol use disorder medication in the last year. There are many kind of factors that contribute to it, but this rate is obviously far too low. And there's many people who can benefit who are not being exposed, or who don't know that they have a medication option even. Many people do not know that there are medications that can help them with their cravings, that can help them with their drinking. Given all of this, I think it's really important to think about what are the major gaps or barriers that contribute to such low treatment rates. People who've heard me talk will know that I really like this kind of 3-circle model. I'm a pretty straightforward person, and I like to think about things in fairly kind of clear-cut ways. And so to me, the 3 driving factors, or the 3 buckets of factors that really contribute to these treatment gaps, are 1, stigma; 2 is the complex symptoms of addiction; and 3 is the way our health system is set up, and how the system itself poses a really major challenge in limiting access to care. I will touch upon these 3 kind of in the next couple of slides, because I think they play out in many different ways, and they really have some pretty complicated interactions with each other too. So in terms of stigma, my belief is that if I had a magic wand, if there was one thing I could do for people with substance use disorders, this is the thing that I wish I could do something about very directly. And it feels like it's something that we can all do something about. We know that alcohol and other substance use disorders are probably some of the most stigmatized health conditions ever. Stigma occurs at many levels. There's different kinds of stigma. For example, there's called internalized or self-stigma, so experienced by the person who's struggling with a substance use disorder. There's also obviously stigma at the societal levels within healthcare systems and structurally too. And it's just important to think about how the different impacts of stigma and how they can play out. I would say the biggest thing that I see is when stigma is what prevents someone from seeking care. And in fact, a lot of people who struggle with substance use disorders, by the time they walk into my door, they've been struggling oftentimes on their own for 5, 10, even longer years. And if there's something I could do about that, right, reducing the amount of time that it takes for someone to feel like they have a condition that deserves treatment or can be treated or something that they can really work on, that's the thing that I would like to shrink, because think about the types of impacts that that person might have suffered and their family suffering for all of the years that they had gone without feeling like they could seek help. We know from the research that feelings of stigma and shame, oftentimes self-loathing, among those with alcohol use disorder are associated with reduced chances of seeking care. And then it's also, when it comes to stigma at the healthcare system level or what's experienced by patients, we know that a lot of patients report that they actually don't prefer receiving treatment in a specialty substance use disorder clinic. Walking into a clinic waiting room, right, into an addiction clinic or something can carry a substantial amount of stigma that really poses as a major barrier for that person to even pick up the phone. And so stigma is one factor of the 3 that I mentioned. I just wanted to mention kind of the impacts of that in relation to some of the other factors. This is, again, from that National Survey on Drug Use and Health. And when they asked people who had met criteria for substance use disorder, why they didn't receive care, stigma reasons might have a negative effect on a job, might cause neighbors or community to have negative opinion, were all major reasons cited by people as why they didn't seek care. However, I want to emphasize that the number 1 reason is actually that people who met criteria for a substance use disorder said that they were not ready to stop using. And that goes to both the underlying symptoms of addiction and also what we know we need to address and what our healthcare system is not set up to address when it comes to truly tackling addiction. That number 1 reason why people are not seeking care is that they're not ready to stop using. And importantly, the next step I would emphasize is that we should already account for this in the care we provide, because we know that substance use disorder is defined as the one medical condition where the person is going to feel ambivalent about making a change. By definition, someone who has a substance use disorder is not going to want to make a change necessarily. In particular, they might be very ambivalent about stopping their use of a substance. They might be interested in other things, maybe reducing their substance use, improving their mood, improving their sleep. But oftentimes, the feelings around that substance or that behavior is really what defines it in the first place. And that goes to this slide, which is similarly in the survey, among all people who did not receive substance use disorder care, which again was 90% of people who had a substance use disorder and alcohol use disorder in particular, what they found is that a very small proportion of them did seek treatment, less than 1%, but they experienced barriers. For example, only 1% of those folks had sought treatment, but ended up not engaging for whatever reasons, insurance, not able to pay, things like that. And then about 4.5% didn't seek treatment, but had thought about it or had wanted or thought that they needed treatment. By far, the majority of people who did not seek treatment did not perceive a need for substance use treatment. And that's the biggest challenge that I would say that we face these days when tackling any addiction. And the hard part is I don't think that as a system, we're set up to really truly treat this particular symptom of substance use disorder. And I'll be talking about that for the rest of the talk. And really that goes at the challenges of our traditional substance use disorder care delivery systems. Many of us work in these systems. I think we do a good job with many things. I think a lot of our clinics and our treatment programs, we really try hard to meet people where they are. We try to be a non-stigmatizing environment. We try to provide the best care that we can. At the same time, if we all took a step back and thought about how addiction treatment came to be in the country, we realized that it came to be in a pretty interesting way historically. There's a couple of good historical books on addiction treatment that if folks have not seen, they're good to read about in terms of, addiction has not been traditionally part of medical systems or medical care. It's come from different groups really interested in, working with or helping folks who are struggling with addiction, which was not considered a medical condition for a very long time. And so the way that these programs were built out, there were lots of beliefs and things that drove them. Some I think were really helpful. However, it defines kind of the care that we see today. And I would say that the care that we know exists today are defined by a few things, which although can be really helpful for many patients, for a lot of patients, like I just emphasized, maybe even for 95% of people who have a substance use disorder, it's really not meeting needs. One is that a lot of treatment programs are abstinence focused, meaning the presumed goal of treatment is abstinence and long-term abstinence. Two is that most of our clinics, I would say, including the ones that I practice in, have general approaches that a patient may be discharged from care if they miss appointments. The hard part is that we know substance use disorders, people are oftentimes missing appointments because they're struggling or they have had relapses. And so what that means is that the folks who might need our care the most are the ones who actually drop out of care the most. And unfortunately, we don't see what happens to those folks. Most clinics don't have proactive outreach programs. And so we end up not kind of able to care for those patients who might need this the most. Third, like I said, the people who drop out of care are likely the patients who need the most care. Pretty much across all research studies, we know that the more complex patients, the ones with multiple substance use disorders, ones with more severe substance use disorders, folks who struggle with lots of psychosocial comorbid conditions and factors, those are the folks who fare the worst in care. And yet, they're the ones who most likely need our treatment, and yet we're not properly incentivized, right? And within our healthcare systems, let's be honest, oftentimes there's a strong incentive to take care of, or to not necessarily take care of the sickest patients. And we see that with emergency room visits and things like that. And so these are factors that we really need to keep in mind and address if we really want to increase treatment rates. And then finally, something that's also really specific to substance use disorder care is we think about care on a continuum, for example, from primary care to addiction specialty clinics to IOP or partial levels of care to inpatient treatment to residential treatment. So you have this continuum of care in addiction care. And one of the challenges is that, when it comes to the general public, if you ask any random person on the street, if you have a friend who's struggling with addiction, what would they recommend? People most oftentimes will say, rehab. And what we know is that rehab is probably not the most appropriate care for the vast majority of our patients, nor is it necessarily the most effective. And oftentimes the level of care is also associated with kind of levels of abstinence focus and things like that too. And so all of these things, especially for the typical patient with alcohol use disorder, which I just said is not treatment seeking, is very ambivalent, and certainly is not interested in stopping their drinking. No wonder people are not reaching out for care. And so all of this information we have at this point, and the question is, what are we going to do about it as a field, as a community, both of researchers, clinicians, family members, community people who care about addressing addiction. And I would say we have come a long ways. And I'll give two specific examples. One is this idea that it's not just the case that someone needs to stop drinking in order to experience benefits. And so this is really exemplified by what's called the WHO alcohol risk levels. This was published about 5 or 6 years ago. And a lot of us are very familiar with it in the research world, but I don't think it's gotten as much traction clinically. And so what they've done is they've taken really large data sets from people across the world and understanding kind of how to categorize people, right? Kind of some of my earlier slides, I said there was risky drinking, there's alcohol use disorder. Well, what they tried to do is they took lots of data to try to categorize different amounts of drinking and the risks associated with it. The goal, though, was to be able to measure how treatment, which might take someone from one risk level to another risk level, not necessarily no drinking, whether or not that was associated with benefits. And so here in this table, it really shows the different risk levels when it comes to alcohol use. And this is not, again, the same as an alcohol use disorder, but this is really applied to the whole population, and different by men and women. And what they found is that for people over time, if they make a change of 1 or 2 risk levels, that is actually associated with really substantial improvements in health outcomes like blood pressure, hypertension, liver enzymes, and most importantly, in someone's quality of life. So importantly, that means that someone doesn't have to go from very high risk to no drinking in order to experience benefits of making those changes. So in addition to that, so that's kind of the one perspective, the WHO perspective. Much more recently in 2022, the National Institute for Alcohol Abuse and Alcoholism, NIAAA, which is the NIH Institute focused on addressing alcohol use, came out with a new definition of recovery. And the word recovery is complicated. I think many people think about that word differently. But what NIAAA wanted to do was, historically, they were very much part of the contributing idea that abstinence was the only goal. And so as they recognized kind of all the data that I just presented, they realized that they needed to help, our communities think about other goals that might be really important for people, even those with alcohol use disorder. And they define recovery as such. Recovery is a process through which an individual pursues both remission from alcohol use disorder and cessation from heavy drinking. Recovery is often marked by the fulfillment of basic needs, enhancements in social support and spirituality, and improvements in physical and mental health, quality of life, and other dimensions of well-being. So I just want to emphasize a few parts of that. So what's important about this definition is, like, for decades, in research studies in our communities, the key thing that we measure when it comes to someone struggling with alcohol or other substance use disorders, how much substance are they using, right? We don't even ask about some of these other things, unfortunately, like at the same rate that we ask, oh, are you drinking or not, or how much are you drinking? And what this definition is saying that from NIAAA, it's important to also measure recovery defined by remission from alcohol use disorder, which means having no more than one symptom of the 11 symptoms that I mentioned. Doesn't mean you don't have any symptoms. Also doesn't mean that you aren't drinking. It just means that you're not suffering the consequences of alcohol use disorder, and cessation from heavy drinking. And heavy drinking is defined by the 4 or more for men, or for women, and 5 or more for men that I mentioned before. And so this idea is that recovery can be defined not just by abstinence, which is the case for some people, which might make the most sense for some people, but it can also be defined in these more diverse ways under this criteria. What we know about recovery and why some of these new definitions came to be is this. Over the last 15 or 20 years, there's been a lot of research following people naturalistically, right? Because we know that so few people were actually getting treatment. Obviously, it was important to understand what happens to people who struggle with alcohol use disorder, regardless of whether or not they get treatment. And so in these prior studies, what they found is that only about 70% of people with alcohol use disorder, or among all people with alcohol use disorder, if they followed people over time, they found that 70% of people actually improved, meaning their symptoms improved without any interventions. They didn't seek treatment. They didn't receive any other help. People did it on their own. And what that means is that they did it on their own in many different ways, or that there were many different paths to that. For better or worse, that means that although our treatments aren't reaching a lot of people are making improvements on their own. What I would like to hope is that we could help people do that faster and also with less impacts for them and their families. In addition, in some of the seminal studies in the field, there was a study that followed people who had been randomized to alcohol use disorder treatment and followed them 10 years afterwards to see what happened. And what they found was that there were different paths or profiles of recovery. And what they found is that in this very large group, thousands of people with alcohol use disorder who had gotten some form of treatment, when they followed them long-term, they found that many of them were not abstinent in 10 years. But they could group people into these 4 categories. They were defined by a low functioning group, meaning people who really struggled with kind of daily functions of life, job, family, things like that, and a high functioning group. And then among those two groups, there was also people who were drinking at lower levels and people who were drinking at high levels. What that also means that there were people in the high functioning group who were doing pretty well with how they were functioning, but who also still had some substantial levels of drinking. Obviously, there were people in the low functioning group who also had, and usually higher levels of drinking too. The thing that seemed to differentiate people who ended up in the higher functioning and the lower functioning group were factors that all of us could probably guess, but were important, including baseline social support, a person's ability to cope with stressors, mental health symptoms. Those were all important things. And you can imagine that those are all important things to try to shift for someone to help them gain recovery too. And again, it was not just defined by their level of alcohol use. So all of this is to say is that in some people, not everybody, but some people can experience recovery, which is defined by an improvement in functioning, no heavy drinking or no hazardous levels of drinking, and without indefinite abstinence. And in fact, this is just the majority of the case. And so what does that mean for us when we think about care for our patients? What I think it means is that as a clinician, I try very hard to be patient-centered in my approach. And I think many of us would say that, but the question is, what does patient-centered mean? And it probably means one thing for one clinician to another. And I think a couple of key foundational concepts are these. To first understand what the patient perspectives and goals are. What's their understanding of what happens, the impacts of their substance use, their behaviors, how it corresponds to their physical health, their mental health. What's their understanding of things? What's kind of the square one where you're starting? The other important thing that we don't always prioritize is, in addition to focusing on helping someone stop or reduce their drinking, or mainly asking about how much their use of substance use is, just as much prioritizing ongoing engagement with that patient. I think this is probably one of the biggest seismic shifts in the field of addiction in the last 10 years. And we see that very much from the MOUD literature, where we know that retention on the medications are a key thing. Well, I see it very similarly in any substance use disorder, where my goal is not just to say, okay, this person, is going to stop drinking. It's how can I help keep this patient engaged with me so that they will come back for another appointment? Because guess what? The majority or many of our patients, even the very few who walk through our doors, are not going to walk through our doors again, because what we might offer is not necessarily meeting their needs, or their underlying symptoms of addiction and their life circumstances are making it very hard for them. And so prioritizing that engagement at the same time prioritizing reductions in their substance use, to me, those two things should go hand in hand. And lastly is working with patients over time, right? And that's what some of the data that I'm showing kind of long-term information about what happens to people over time can be really helpful. Some of us, when we work in really inpatient or acute care settings where we're seeing patients very sick, it's very difficult to think about that. And obviously there can be really acute risks and things. But in situations outside of that, it's realistic to know that, most changes take time. And the most important thing is to have that ongoing engagement and trust with the patient so that you can help them over time, and not necessarily that something is going to change, overnight. Sorry about that. So I wanted to kind of round out some of these discussions and hopefully generate some questions with a case. I'll read this case. My thought is that this case should be consistent or reflect a lot of the patient scenarios that we probably all work with. And I want everybody listening to this, to think about how they typically would approach a patient like this, or even think about a patient they've worked with who might kind of have some similar presentation. And if you can think about how kind of what we've been talking about, how that might make you think about either different ways of approaching someone like this, and maybe the problems that you think that you would face if you tried something different. So Mr. S is a 52-year-old married white male who works as a lawyer with history of depression and hypertension that you're seeing in primary care. You noticed elevated liver enzymes and some difficulty that he was having managing his blood pressure. He says that he's been struggling with work stress. He typically drinks 6 beers every day, but has recently been more depressed with severe insomnia and drinking up to 12 beers a day. And when you asked him the questions the DSM-5 questions, he met criteria for moderate alcohol use disorder. He says that his last primary care doc told him to quit drinking, but he's not interested. He wasn't interested then. He's not interested now. He feels like it's helpful for him. And he doesn't want to make that to quit. He says he's also a really private person. You had offered, does he want to talk to someone? He says, no, I don't want to talk to anybody. So how would you approach someone like him at this point? Would you stop there and say, okay, let me see you in 6 months? What are some other approaches that you've tried that have either worked or not worked? I just asked you to include some of that in the chat or in the Q&A, and we can talk about that. And so as you're kind of putting some things in the chat and things like that, I just wanted to emphasize that these are complicated situations. I'm not saying that I have answers. I'm not saying that there's a clear right or wrong way to approach patients, but I want to just fully be transparent and articulate why these are challenging situations. And we all work in different settings, right? Some of us might work in the legal system or with patients who are incarcerated. Some of us might work with pregnant populations. So the complexities play out in lots of different ways too. And so the tough questions I just want to name so that we all have them in our mind is that, yes, abstinence may be the easiest thing to recommend. Of course, it's the safest. It's the easiest thing to come out of my mouth, right? There's obviously no controversy with, yes, if someone is struggling with alcohol use disorder or very heavy amounts of drinking, it's easy for me to say you should stop drinking. But what are the different impacts of that? What if the patient is not interested? What impact does that have on someone? Does it matter what impact our words have? Or does it matter just what we actually say? What about people who experience some of the severe consequences from drinking? Let's say they have severe alcohol use disorder, drinking a fifth a day, have had a history of complicated withdrawal symptoms, where abstinence clearly is the safest, or someone who's tried to cut down on their drinking but has had a hard time and has gone back up. How do you approach that patient? And then lastly, I think most importantly, is what does it mean to provide the best care for someone struggling with alcohol use disorder? Does it mean, like, we told someone that they need to stop drinking, we refer them to, psychotherapy, we told them that there's a medication treatment, and that's it? I don't know. So what I want to emphasize is that the amount of drinking is obviously a very important thing, including in particular folks who are drinking at risky amounts. But like I said before, to me, the other things that we have under prioritized is patient engagement, patient-centered care, understanding where people are coming from, and then also supporting data-driven recommendations. One of the things as the addiction psychiatry training director that I always try to emphasize to our trainees is this, that every person is different, right? We know that no matter how much research studies we have, it's only about the average person. And with every given patient, I try to have a conversation like this, which is for someone who's drinking, let's say at the quantity that Mr. S is drinking, I would say, some people might tell you that, yes, you should stop drinking. It's having impacts on your health. What are your thoughts about where you're at and what you're interested in, and how does it feel, and what's the role of drinking in your life? So understanding where they're coming from. And then if the person says adamantly, no way, no how, like, I'm not ready to stop drinking, I might say, I hear you, I really do. This is something that you've had in your life for quite a long time, and you see some positive impacts, and you're not ready to make that kind of a change right now. Is it okay if I talk to you about a few things? First is, I want you to know that I'm going to walk by your side. I'm here to help you no matter what, no matter if you were drinking more, no matter if you're drinking less, no matter if you're not drinking at all. And in fact, most of all, I want to see you when you're struggling, right? Clinically, it's easy for us to have a visit with a patient who's doing great. All of us love that. But what I want the person to know is that when they have the most stigma, when they feel the most shameful, let's say if they increase their drinking, that's the time that I'm most wanting to see them and try to help them with that. I'm not going to be the person to judge them. The other thing that I would say is that I am totally here. I'm happy to work alongside you if you're interested in making a change. If you're not ready to stop drinking, to what extent are you interested in making a reduction in your drinking? Here are some different things we can try. Here are some medications that can be helpful to you. Here's different psychotherapies, or if you're not interested in the psychotherapy, we can start with the medications first. But the one thing I want you to know is that we need to collect data about you specifically. We know that some people can actually do really well when they make a drinking reduction and they can really see benefits in their lives. Other people, when they try to do that, they find out that they are not able to reduce their drinking. And sometimes people need to actually try to stop, or stopping works out much better for them. I don't know who you're going to be. I just want to make sure you know that I'm going to be reflecting an honest truth to you, because sometimes your brain is also going to play some tricks too. No matter what, I'm here working with you and we're going to do this together. That's kind of the conversation that I mean when I mean patient-centered care. Lastly, I want to talk about some of the work that we're trying to do in this area. Like I said, I've emphasized kind of a lot of the challenges that we experience, including, those of us who work in addiction clinical settings. And so one of the current research studies that I co-lead with Dr. Erin Bonar, who's a clinical psychologist in psychiatry, and she's also part of my ACRE. It's a project called EnReach. And it's a project where we are trying to address the barriers that I named. And this is just the tip of the iceberg. And in this project, what we do is we actually identify all people in Michigan medicine, and we're also starting to work at the Ann Arbor VA, who meet criteria, who likely have an unaddressed or untreated alcohol use disorder, so the 90%. And it's important because when we put in this application to NIH, we realized that almost no research had ever been done on reaching or engaging that 90%, even though we know that that's where the disparities and the gaps lie. And we don't stop there. So we identify people with untreated alcohol use disorder. Then we outreach to people using a motivational interviewing approach, engaging them in the treatment intervention that we're offering. And then we provide them care via telehealth that's patient-centered. And so some of you guys might be thinking this sounds a little bit similar to SBIRT, screening, brief intervention, referral to treatment. It's similar, but I would say the key thing that we do, SBIRT has the key barrier or challenge with SBIRT is that the referral to treatment, the RT, has not been found to be effective because patients do not engage when we provide referrals because of all the barriers that I just noted. And so in this model, we actually provide care directly to them via telehealth at home. And so we're currently in the middle of a randomized controlled trial testing this. We have a few other studies that are similar to this, not just in alcohol use disorder patients, but in patients with other substance use disorders, to try to test if we kind of flip that model upside down, whether or not we can address some of the major treatment gaps that we see today. There's tons that need to be done in this area, but I just wanted to give one example of what a different approach might look like in real life. What we found already is that a lot of the folks who engage with us in this research study, which is hard because they might get randomized to treatment or to control, we're reaching people who haven't had treatment before at all, who tell us they've not been willing to talk to anybody about their drinking, and they were afraid that we would tell them that they would have to, quote, stop drinking. That those were always barriers, but a lot of folks have been thinking about trying to make a change. And the goal of this program is to really support and help them do that. Some people, meaning that their goal is to quit drinking. Some folks really want to make a drinking reduction. Some people really want to focus on other things, including mood, sleep, pain, other functional impacts. But this is really a program hoping to engage people across that spectrum. All right, I know I'm really short on time, so I'm not going to say anything else in summary. I know that there's probably some Q&A questions. So Melissa, if you wanted to help me parse through some of the Q&A, I'm happy to take some questions.
Yes, I'm happy to help. Before that, I think we're going to just post the CEU slide with the codes for obtaining credits. But while we put that up, I can start with the questions. Is there a model of care that can be downloaded for potential use?
Unfortunately, we're just, we're doing some of this in the research world. We have like a website and things like that, but we don't have the materials quite ready because we still have to demonstrate that this is effective. What I want to emphasize, though, is that without downloading, the key things being, first of all, screening people for substance use using things like the Audit C, drug screening, single item screening, and then providing brief interventions, treatment engagement for those. So kind of that SBIRT model, those are really what we know to be the effective treatment models or the evidence-based treatment models. The thing I'm emphasizing here is that when it comes to that last piece, the RT, first of all, it doesn't mean just abstinence, it might mean engaging people along that spectrum. And so although we will be working to develop more materials and things like that, those basic ideas are basically what I've outlined in the talk.
Thank you. If everybody can just direct you to the chat for the link for the McBAP and Social Work CE credits, as well as the CME credits. It's in the chat. Okay. Can you speak to any real contingency management programs that exist? It's all theoretical to me. I haven't seen any programs that my patients are actually eligible for.
I love that question. The answer is yes and no. Our team just published 2 studies in the VA. The VA has been the one healthcare system in the US that's undertaken the largest implementation of CM, continues to undertake it. And so we are working very closely with our VA operation leaders, so the Office of Mental Health and Suicide Prevention, SUD director, to evaluate the contingency management program that has been implemented VA-wide. That's not an answer to the question that you asked, but the key things I'll emphasize there, because I don't have a good answer for you, is 2 things. One is what we found from that evaluation is that it's not just important to have, quote, CM. Like the things that the VA has done to help clinics implement it are basically office hours, things like that, learning from other clinics that have been doing it, providing the incentives. The VA actually provides the incentives. The patient doesn't, like clinics don't bear that brunt. The most important thing, as some of folks know, is that currently our policy does not support CM because, at least under SAMHSA, there's currently a very severe cap. We know that contingency management is usually effective when overall contingencies are in the couple $100 range over weeks or months. And currently the caps are much lower than that. That's currently undergoing a change in the state of Michigan. There's going to be a CM demonstration project being rolled out in the next couple of years. So there might be more availability of that. And hopefully one day I'll get the opportunity to talk to you about doing that at some later date.
Thank you so much. Do you think individuals with alcohol use disorder seek treatment less often because of the social acceptance of using alcohol?
Yeah, there's definitely a component of that, right? Like I think one of the key things I was trying to emphasize is that we have very diverse like population of people when it comes to drinking, right? There are people who are curious. There are people who experience a lot of stigma. There are people who don't really feel like there's any negative impacts. And some of that has to do with social acceptability. Obviously, where that's really shined a light is in the college age population, where social acceptability is very high. And substance use and risky drinking is very high. So I definitely think there's part of it. The other part that question makes me think about is obviously other substances like cannabis. And so that's why for me, the important conversation to have with patients is a very patient-centered one. It's it's not about judging or determining if a substance is good or bad. It's really, let's talk about you and what your experiences are, right? Like your friend might have all the best experiences, whatever, but like all of us are so different. Like, what's your personal experience like? And I hope that you can be honest with yourself and me about what your experiences are like, and let's talk about it at least.
And I want to be mindful of the time, but I know we have 1 minute. Are you able to share any detox protocols for AUD?
Great question. I did not have those in my slides. I'm wondering if we have any resources like that for open, but there's certainly detox protocols. Usually they're about medication treatment with benzodiazepines, some with gabapentin and such. Depends on inpatient and outpatient settings. So we can see if there are any available through open already.
Certainly. Okay, we are at 1 o'clock. Allison, thank you so much for this very valuable information. This was very, very good information. And thank you for being here today. And thank you everyone else for being here today. I hope you have a good rest of the day.